Good evening, everyone, and thank you so much for being there for this evening webinar, the usual Thursday CCI webinar, which everybody looks up to hear from the experts. Also wishing the viewers and my co-panelists here a happy Navratri, and to you and your family. We have a very interesting webinar today and very challenging one for me, which is the respiratory system clinical examination, a lost art. When I was given this topic, I immediately I said yes, but I found it very difficult. I'm very nervous today, actually, not because of the topic, because the panelists which are there in the photograph, they don't look like my panelists. They're all looking different. Surya Kant is looking different. Radha Munje is looking different. Rakesh is looking different. So I'm wondering whether I have the same panelist. Anyway, it's nice. It is a great concept by Dr. Krishna and his team and Vijay and the technical team. Thank you so much for initiating this webinar. And as we move on into the era of gadgets, electronics, and where the human touch has taken a backseat. And it's very appropriate that we remember this, and then we come back to our good old days of clinical examination. There were various suggestions. I was looking up, actually, after seeing this title, to see if there are any kind of literature on it. And I found several books on this clinical examination. And in fact, there were many even now published on clinical examination of respiratory system and so on. And it was great to go through some of them. And I also watched Subhakar was mentioning about go through the TED talk by Abraham Varghese, who is my role model and a favorite, being also a pulmonologist and HIV physician. And some of the books way back in late 1980s, when I was in UK, like he published the first book on my own country, was having a great effect on me, and I wanted to practice like him. And HIV medicine in those days was very primitive. Patients were dying all over, all around us. There was no medication. There was only human touch, where he goes to various homes to examine patients and to take care of them. It was a great book, My Own Country, by Abraham Varghese, who also had some training in India, I think in Bengaluru itself. So Subhakar, thanks for suggesting that TED talk, which I had heard earlier, but very great talk. And subsequently, if you see many of his talk only on human touch, on examination of various systems of pulmonary medicine and other, including neurology, is there. So all of us recollect our old days of the clinical rounds, whether it is undergraduate or postgraduate. We remember our good old professors. Many of them may not be there, so I want to pay my respect to many of them who are not here and who are great clinicians. They had only probably an X-ray or fluoroscopy. Even in my 1982 to 85 in MD, we had only fluoroscopy. We were supposed to do only fluoroscopy, and we relied on examination of the patient, taking a detailed history and practicing what is called as the clinical examination of rituals. Even Abraham Varghese mentions about the ritual. These are all rituals that we should not forget about, whether you become a great physician or just about starting this as career. So there are no postgraduates here, I was told. That's why I'm saying including juniors and including everyone. And as somebody reminded, during the COVID days, many of us have not examined patient, not taken detailed history, but we still manage. But this is a different era. So many of these challenges that we face and we adopt, but one should not forget about detailed clinical history and examination that we were all taught about, and especially junior chest physician must practice. And then when you go on to become a senior or more experienced, we all learn how to shortcut and cut down the time, but still valuing the basics of examination and history taking, which should never ever be forgotten. You cannot become a great clinician unless you have practiced all those rituals in your younger days, and then go on building up easily about the practice of chest medicine. So the history taking is so important. All of us know about it. And I was told that the modern day clinicians generally interrupt their patients every 14 seconds of the exam of their history taking. So it's important that that we don't interrupt, sit quietly. Many a time, even I have been faced by a patient saying, "Can I speak to you for 5 minutes?" They are pleading. Can I speak to you for 5 minutes? And then, oh yes, please go ahead and do it. But we start interrupting them. But we should just leave them alone, and they go on talking about it. And they give so much of information that you just cannot examine. And many a time after examination, you then get back to some history taking you would have missed. For example, just today, I had a patient who was referred to me and said ILD, and started treatment by another physician and saying it is a post-COVID fibrosis. And when I took detailed history and my other associate took detailed history, we found out that she had, for the last 1.5 years, her oxygen level was always low. When she went for vaccination, the nurse there who checked up said that your oxygen is low, madam, and is it okay? She said, no, I have always had low oxygen. So which means she had hypoxia. And when you take a detailed history, she says she was feeling tired, but because of the COVID, she didn't. And then developed COVID in April 2021. And subsequently, she was monitored at home, which means it was not serious. But the physician probably didn't pay attention to the patient's history, which she was revealing in the interview, saying that she always had hypoxia, and the CT scan, of course, showed a non-specific interstitial pneumonia. So history taking is very, very important. And then as I went through a lot of history of how the great clinicians of 1980, 1876, and then on, like, for example, percussion was invented by Joseph Leopold Unberger, and he saw his father percussing or tapping the wine barrels, and then found out, oh, there's something that I have to apply, and then he did that. And similarly, the great the physician Lennox, who invented stethoscope. So if we go back to all those history, it's so humbling and so important that we even now base our diagnosis depending on the history. So a good history and examination is so important, examination in detail, and then added by various investigations, simple investigations, that would be enough. One of my Professor KG Das, I would like to mention him. He's 1991. Even last year he was practicing, but he was taking only 2-3 patients a day and would examine patient for 1 hour. I was thinking, what was he's doing? He would examine from top to bottom. whether patient had neurological problem or any other problem, he would percuss. He would also do all the rituals which I was mentioning, including the knee hammer, checking the knee jerk, everything, all clinical, like 1 hour per patient. Of course, it's difficult for us. And you can imagine he came as a patient to me, and then I was very nervous and trembling. What would I do for a professor of his stature and very well-known teacher, Professor K.G. Das? Me and Murli Mohan were taught by him. And similarly, many other teachers, all of you would have had, and especially neurology, I was told by one of my professors, the diagnosis is done at the end of history taking in 80% of cases, 10% by examination, 10% or even 5% by investigation. So with this preamble, with this introduction, I would like my other panelists who are there, whose introduction I haven't done because they are all very well known and it's there and circulated. And let me go across to each one of them to make a very short opening remarks about the history taken and clinical examination. And then we will go on with each one of you contributing to palpation, percussion, auscultation, detailed history taking, and so on, and how it has helped you in arriving at a clinical diagnosis. Thank you. So each one of you, start with Surya Kant. I can see him straight away. So start with you, Dr. Surya Kant. Opening remarks, short one. Thank you.
Okay. Thank you, Dr. Satish. Namaste to everybody. And of course, it's a wonderful, pleasant meeting today evening on a very important topic. First, I think it is not lost. So my first comment is that we should not say that it is the lost art. It is the continuation of the art. Intensity may be decreased, but it will never last. It will never last, and it has not lost. So this is my modification to the topic. Because if it would have been lost, probably we were not discussing it on this panel discussion. And it's still the important first aspect of the clinical part of the every curriculum, all across the world, all across our country, all across all medical colleges, institutions in the country and globe. Of course, we are learning. This is part of our curriculum. And still, I'm happy that younger people, I can remember one of the fellow from Guwahati, I just forgetting his name. He has written a very important book on the clinical examination or respiratory history and of course physical examination. So I think still people write, and one fellow from Shimla, that is Dr. Malay Sarkar. He's writing a lot of review article on like auscultation, like physical science. He has wrote in Annals of Thoracic Medicine. He has written a review article in Lung India. So still even the younger fellows, they are of course concerning the importance of history taking and physical examination. One of my teacher of medicine, Dr. Sarkar, he used to say that making a diagnosis, it's a parallel with the CBI investigations. For example, a criminal or anything happened and the cases happens, of course, given to the CBI. And the way CBI started the examination, of course, the same kind of thing a doctor has to do. So I think history taking and examination are the wonderful, evidences, wonderful tools for approaching or heading towards the diagnosis. And of course, we can have the parallel thing about the CBI or any investigative agency in this country. Similarly, of course, we cannot ignore rather we are not ignoring, we are using more and more digital, as you said in your introductory remark, we are using more digital, more of course logistics, more of the investigative tools, of course recently developed in last 20 years. So more the investigative tools, they have been developed in 2-3 decades. So I think it's still in the 2021. And very interestingly, this Krishna has, of course, Krishna is always You see, he's a very imaginary boy. He's always coming with, of course, certain innovative kind of topics. And this time also. And the very important thing is that in 1921, actually the important Hammond sign. So we are celebrating the, of course, confirmation of invention of Hammond sign as a century, because he was a French scientist, French doctor, and he invented this sign in 1907, and later on he confirmed in 1921. So we are celebrating this. I think this is the wonderful tribute to the centenary celebration of this sign also. So thank you, Dr. Satish and Dr. Krishna. Of course, wonderful organization on this topic.
Thank you, Dr. Surya Kant, Professor and Head from Lucknow. Now, let me ask my friend and a well-known pulmonologist, Dr. Radha Munje from Nagpur. She is the Professor and Head at the IGGMC Nagpur, President of Vidarbha Chest Association. Dr. Radha Munje, your opening remarks. Thank you. Yeah, I think muted.
Yes. Thank you, Dr. Satish, and of course CCI for bringing up newer topic which are more relevant. When I look at this topic, I feel that this time is very correct to not discuss this topic, but disseminate that whatever we have learned, probably in history taking and examination, we have unlearned all that with the fear of COVID. And now what we are trying to do is relearn to stick to what we have already achieved or we have already practiced before. That is what I think. And it's very important. It's important for everybody. I mean, to our new students, the students who are yet to come out as qualified pulmonology. Of course, we insist on all these things. However, whatever they have learned when they go out with a pulmonologist degree or a qualifying qualification is that whatever they have learned, they should practice it. One thing. Second important, I feel the importance of today's webinar is what we are going to do is emphasize on the individuality of the patient and what does the patient want. Usually we look at a patient and we want a history. We want something, but we have to look the other way around that what does our patient need. So our patient wants us to know more and more about his disease, the course of the disease, and they are willing to come forward. Many times we have seen that when we ask something to the patient and patient answers, few of the people who are with us, I know I should not be using the word of juniors because all of them are our colleagues, whether they are our students or other people in the department. But they have, the changed expressions, and then they say, "Ki humne bhi yahi question pucha tha," but he did not answer, or he told me something else. He said 10 days. Now he's telling something different to madam. So see, you and me do not have a magic wand so that the patient would come out with the answers. Then what do we have is that because when we are talking to the patient and the time that we are giving, we are listening to him, they feel confident. Yeah. And they want to confide in us. They want to come out with everything that you ask. So for that, you have to practice this every day with each one of your patient, because each patient is individual and each patient is going to teach you something new. We are all learning forever. वो तो हम हमेशा ही बोलते हैं. All of us are learning. Then who is teaching us? It's our patient who is teaching us. And just to add, we know we have an array of investigations, but if you look at the bottom line, the last line after the cutoff is even the pathologist, even your radiologist, even your immunologist would write that boldly. Kindly correlate clinically. So even with a report from anywhere, if it's written this, then I feel that we should have taken a history prior. we have examined the patient and have come to a provisional diagnosis. And whatever investigations you do would be supporting your provisional diagnosis or ruling it out. That is, I think, is very, very important, and people should, and everybody of us should keep in mind. Thank you.
Excellent, excellent, Dr. Radha. You really hit the nail, especially about the juniors. And they come and say, as you rightly said, that he didn't tell me all this and he's revealing all this to parents. So it will happen, and then each one of us learn, and then they will go on to become seniors, and then they will face the same problem. At the same time, you also brought out about the other departments. I fully agree. And one of my professors used to say, whenever he used to put up an X-ray, he knows that the X-ray is badly taken, tilted, overexposed, but he will keep quiet and say, he will never comment saying that it's a badly taken X-ray, badly done CT scan. And he says that, they're also your friends, you're also their colleagues, they're also trying to help you, but it may be a bad one, but you can always talk to them secretly and not in front of the patient. Very well said. So let me move on to my good friend, Dr. Subhakar Kandi, who is joining from US. Can you believe it? He is, the time zones are different, and then he gave us some good inputs before the webinar. And he's here. He is the professor and head of the Department of Respiratory Medicine and at Hyderabad at the Kandi Academy of Medical Science, and a well-known teacher, well-known to all of us. And he's also the South Zone Chair for Indian Chest Society. Over to you, Dr. Subhakar Kandi from US.
Okay. Thank you, Dr. Satish. At the outset, I must congratulate CCI for taking the initiative, especially to Dr. Krishna, who is my brother, for taking this a new topic for discussion. When you ask me my introductory words, when I'm a second year student at medical college, I used to go to the library. There was a quote in the library. We all know the father of modern medicine, clinical medicine, is William Osler's. The William Osler's quote always reminds me, the going to reading without books is going to an uncharted sea, was the quote. Suppose if you don't examine, not going to see at all. So the good clinical examination is an indispensable tool for the diagnosis and management of a patient. And I used to say my students during my clinical rounds, usually even after 60 years also, I have not forgotten this art at all. I spend 1.5 hours during my clinical rounds. And every students think that once you pass the post-graduation, once you present your long case in the exam, that ends the clinical examination. From the next day onwards, they go to the CT scan chest, even without basic X-ray also. So I always say my students that Ranjan's tube is not a substitute for Lennox tube. So always a good clinical examination history is an indispensable tool. And as Radha has rightly pointed out, correlate clinically. We are not treating the reports, we are treating the patients. You have to change our mindset. Always you are not treating the patients based on the clinical history and physical examination only will arrive at diagnosis. As you rightly said, Satish, 80% of the neurological case diagnosis lies on good history taking. So history taking is an indispensable tool. Clinical examination is an indispensable tool. I say two of my real-time experiences without wasting much of time. I have seen a patient who was already seen by 3 senior pulmonologists and they could not arrive at diagnosis. They have done all the investigations, including the CT carried biopsies, bronchoscopy. But when I examined the patient, there was a lymph node, cervical hard lymph node, which they have forgotten. And the biopsy was inconclusive. When we took the lymph node biopsy, the patient was diagnosed as carcinoma. And similarly, one more case, the patient admitted with a pulmonary embolism. All the investigations were done. They could not identify why the patient is getting clots, and patient was started on anticoagulants long term. So when you have seen the clinical examination he has a thoracic outlet syndrome, we ask the patient to turn to the right and you have observed the pulse is disappearing. This is simple. Do you need so many investigations to diagnose this with a simple test? I think the better history and clinical examination are indispensable tool. And of course, with a lot of consumer codes, and we are forced to do the investigations because we are living in an era of evidence-based medicine, particularly in US. Unless you do a special investigations, you can't arrive at diagnosis. But that doesn't mean we have to not to rely on the history and clinical examination. I can understand the limitations of the time constraints. For example, if you want to see the, like Professor Das, 45 minutes a case, we can't see, I think Satish may be seeing 40 to 50 patients in his OP, busy OP. It may not be easy to, so I think there should be some balance. There should be some balance. You can't spend so much time on the clinical examination. Once you are experienced, you know how to see like a short case, 10-minute short case, and see come to a conclusion. With this, I thank you once again, Satish and CCI, for giving me an opportunity to be a part of this wonderful webinar.
Excellent, Dr. Subhakar Kandi, your initial opening remarks, and I can't agree more than what you've said, especially regarding the investigations and where we should not be treating an investigation and we should be correlating with the clinical, which happened during the COVID time. And all of us know as seniors that many of the physicians, I'm not blaming anyone, trying not to put a hand on that. I'm just trying to say that many of them treated the CT scan rather than the patient. Patient had absolutely no symptoms. Patient was fine. Their oxygen levels were fine. There was not an iota of evidence of hypoxia, but the CT scan showed something, and the treatment was given to the CT scan, not to the individual.
Yeah.
Okay,
in fact, sorry, Satish, I have seen patients treated on to death with anti-tuberculous treatment for a sequel of lesions on the chest X-ray, without taking proper history, and patient has symptoms or not.
Yeah, absolutely right. Absolutely right. Okay, so let me come back to the last one, but not the least one. Dr. Rakesh Shawla, he's well-known in the field of pulmonary medicine and critical care, and he's been a great teacher, and he participates in all the academic activities. He is from the Department of Respiratory Medicine, Critical Care, Interventional Pulmonology at Saroj Super Specialty Hospital, New Delhi, and Jaipur Golden Hospital, New Delhi, and also at the Rajiv Gandhi Cancer Institute. He has large experience in critical care medicine and also in respiratory medicine. Dr. Rakesh Chawla, your opening remarks. Thank you. You have to unmute. Rakesh, unmute. Yeah.
Thank you, Dr. Satish. Thank you, Dr. Krishna, for an innovative concept of history taking. Things have changed from physical to digital. We are discussing and trying. As Dr. Surya said, it is not lost, it will not last. But let it put it straight now, for last 1.5 years, not me or anyone, as a physician and allied specialties are on digital mode rather than physical mode. And as Surya has said, November par to naya par. Right? We hope things should return and we should be back to our magic charm of examination and history taking. And as Dr. Krishna, being a God believer, patient walks into you and he says, "Aap mere Bhagwan hai." I tell them, nahi, Bhagwan aap hai. If you will not visit what I will do here sitting and I get bored. So you must listen to the God who comes to your clinic or who is admitted in your hospital. Give him patient hearing of 5 minutes without interruptions. The attendant with him also wants to give the put-ins, the inputs when the patient himself few things doesn't know, especially when it comes to snoring and sleep apnea. The witnessed partner is witnessing that history. So give them an equal opportunity. Then I tell my juniors, my students, we are not treating the lab. Patient is hale and hearty. Please treat the patient. If he is all right, don't worry about SGOT, SGPT is raised, or little amount of urea create is disturbed. Give some time the body to heal and let things settle down with the time rather than running and treating and overcorrecting the investigations. That is very, very important. Next, I remember, and the book which Suryakant was mentioning is by Basant Hazarika. That is a beautiful book on respiratory examination, which he must have put in a lot of efforts to give it. And today's PGs and the DNB students are all reading, sir, with regards Basant Hazarika book, which you were mentioning from Professor in Guwahati. So
yeah, thank you, Dr. Rakesh Shawla. I just forget his name. Yeah,
correct.
Otherwise I have visited so many times Guwahati and I know him very well. Yeah, Basant, he is Basant Hazarika, yeah.
Yes, I know. So, Professor of Respiratory Medicine, way back 86, Professor M.S. Parmar, Professor Baldev Raj, by the time they reach at percussion, they will make the diagnosis before coming to auscultation. So, our neurology professor will make a diagnosis only on history. And I tell my students, come and stand when the new patient has arrived in the ward, just for 5 minutes with the bed of the patient. Just wait. Don't talk anything to the patient. Let him talk. All vibes, all things will start coming to you. What has been missed in the night, you are going to see it is coming up on the surface. You are not touching the file. When you open the file, you know kahan pe glitch hai, kahan pe kya gadbad hai, kahan X-ray mein gadbad hai. 5 minutes you must stand. The problem is we physicians don't have those 5 minutes to stand with the patient silently and listen him and wait for the vibes, a relationship, what they call it as an aura between the physician and the patient, which is God gifted to the physician, is definitely there. And by touching the patient, you are going to give a healing touch. This touch God has gifted you. There is a time when patient asks, sir, mujhe haath to laga lo. Mujhe अच्छे से देख तो लो. And this is a gift of God when you touch the patient, that if you are, I am a strong believer of God. I will not go to the debate of this, but yes, that healing touch is with you. So you should not forget the art of history and examination. And it's very, very important. So I was seeing in chat box that NMC should fix the guidelines and make it all that 5 minutes is a patient's right. He is coming to the private chamber. I do not know about the government people. They have so many patients sitting for 9 to 12 OPD, and everybody wants Professor Suryakant. Everybody wants him to see, which is next to impossible. The things have to be rationalized, as said, not 45 minutes and no time given to the patient. So I think we had to rationalize and channelize the things. And there is no doubt about the history. You go to pathology, when we submit the specimen of, say, thoracoscopic pleural biopsy, the pathologist wants, sir, history likh do, ye tissue kahan se liya aapne? Kyun liya aapne? He is going to help you in diagnosis. Same way radiologist, sir, aap kya soch rahe ho is patient ke bare mein? So that what he is missing on CT or X-ray will come up with the discussion which you are looking for. So history taking is an art, and it has to be developed by the younger generation, which is now getting born in a digital mode, and things are getting digitalized. So this is what I can say. Thank you very much, sir.
Thank you, Dr. Rakesh. That was excellent opening remark, especially the one you mentioned about the bystander or a patient's attender, who is also going to chip in and give some clues about the diagnosis. It reminds me, a long time back, I had a gentleman, a senior man. and who had come with a pneumonia, very severe cough, not diagnosed, given various antibiotics and not better. And then he came to me, and then I was clueless. And then I saw the X-ray, and after that I said several antibiotics given, but severe bouts of cough. And then the daughter-in-law, as they were about to get up and go, I had no clue. She says that, sir, he does what is known as oil pulling. It's a ritual of, gargling the throat with oil, the castor oil and things like that, and doing all this oil pulling. Then I said, oh, does he? So I asked him to sit down and took some detailed history, and then asked her, and then he was pointing towards her, saying that don't tell all this to doctor, don't reveal all this, thinking that it's not important or what he's doing is wrong. Then I said, please spend some time, tell me about it. Every morning he's doing this oil pulling. Then I said, this is definitely a fat induced pneumonia, lipoid pneumonia. So I did a bronchoscopy, demonstrated the lipid body, and then thanks to her, I could diagnose and get him out of this and then make a diagnosis. Excellent remarks. And we all remember about various clinical scenario, which you mentioned, Dr. Rakesh, that juniors must sit and stand and watch the patient, and you will get a lot of clues. And my friend Dr. Subhakar Kandi's suggestion of listening to TED Talk by Abraham Verghese, he mentions about this, like Surya Kant mentioned about a CBI investigation, and the patient walks in Scotland, Edinburgh, and then he goes on saying, looking at the patient, so you are from Burnt Island, and how far is it? And how did you walk? I know you took a shortcut. Just looking at the feet of the patient, where there was a red soil or something, which is seen only in this particular area. So on and so forth, you pick up so many things, and it's so interesting. Surya Kant mentioned CBI investigation, absolutely right. And Subhakar and all of you contributed to this this talk. Excellent, and we all remember how important it is. As you rightly said, it's not forgotten art, but we have to keep stressing on the important, as Dr. Rakesh mentioned, that Surya Kant may have about 100 patients and so difficult to examine each one of them. But with experience, we will pick up. But what the juniors must go through is the ritual, and not like what we all do, because we have all become seniors. We have a lot of responsibilities, not only just spending time with the patient, but also other things. So we know how to practically diagnose. And regarding history taking, as Radha Munje was mentioning to me just before the webinar, especially asthma, a simple disease for all of us. It's a bread, butter, jam, everything for all pulmonologists. And patient, what problem you have? I have asthma. So don't believe or don't listen to the diagnosis of asthma. And every day, including today, I had 3 patients who said that they have asthma and bronchitis. And then all 3 patients had hyperventilation and anxiety due to the COVID times and so on. So let me concentrate and see specifics of this clinical history and examination. Let me invite Dr. Radha Munje. So your thoughts on history taking and general examination, what you would like to stress the juniors and others, and for all of us. I don't mind going through again all the things that I did, and which is, when you do it, you don't forget it. You remember. It's all in there in your mind. The examination of the trachea, the inspection, palpation, percussion, auscultation, what type of bronchi, what type of breathing, is it tubular breathing, cavernous breathing, amphoric breathing. We just can't forget it because we have spent hours and hours on examination of the patient. Over to you, Dr. Radha, regarding history taking and a general examination, some comments about it and the importance of taking a good history and examination.
Yes, thank you, Dr. Satish. We all know that history taking is the first step to introducing yourself to the patient, and the patient's details would also be introduced or told to you. So the importance, I don't need to talk about it. All I would like to say that spend some time in taking history. So everything is important, like from the name of the patient, the details from where patient has come, what does the patient do, what is his occupation. That is very important because in the end, it's going to give you a clue towards the diagnosis. Secondly, when you are talking with the patient, the more time you spend, more comfortable the patient gets with you. Patient would come out with many things about his presenting illness as well as few things which must have happened in the past. बहुत से पेशेंट ऐसे होते हैं that they want to elaborate more on the past history. I went to this doctor, I did this, I did that. So what happens is everything related to the present illness gets clouded. So you have to learn, it's an art as well as it's a science. So what you read in the books, how history is to be taken, history of presenting illness, history of previous treatment, everything is written in the books and that's a science. How you apply to the patient is an art. And how to apply it within few minutes is, I think, is a very skillful activity for any doctor. I would also suggest that as you go on to examining the patient, when you hold hands of the patient and start with the general examination, please do continue with what you were asking to the patient. Give some replies to whatever answer the patient is giving. For example, you ask, "Aapko cough, khasi kab se hai?" And he has told you everything about his cough. And now you have started examining, but something is remaining in the history. So you can ask that what medicines you have taken while examining the patient. So you are spending time with the patient, gaining his confidence, and you are taking all the details of the history. I would not take this platform to teach history taking. Like I would not tell you that how you should extract the history of cough, how you should extract the history of fever, and what does it indicate, like high grade fever stands for what and low grade fever stands for that. That I'm not going to tell you. But all I can say is that when you are examining the patient, do talk to patient and look at him. Some eye-to-eye contact and believe in yourself, the magical touch that you have in yourself. You believe in that. And when you touch your patient with that, patient would come forth with proper history. He would cooperate for examination and you would be going nearer to the diagnosis of that particular patient. Here, I would like to tell two examples of my patient. One is a very old one. You know that in 80s when we were practicing, we were pulmonologists, but most of our work was related with tuberculosis. And there was a young female who was admitted. And as was the dictum at that time, that when you go and you talk to the patient, you would necessarily stand on the right side of the patient and start taking his pulse. Whatever is being told by the residents or juniors, or if you are a senior resident, still you would hold hands. And as soon as I touched the patient, I could feel that the hands were uneven. Where you put your fingers on the radial pulse, it was uneven. And then I looked down. And what I saw was that her hands and body was full of molluscum contagious. These are the times of late 90s, and we were not so, well versed with HIV, and we did not doubt. But because she had extensive molluscum, we got tested and the reports were positive. So had we not looked at that and we would have kept on saying this is a rash, then perhaps an important coexisting disease would have been missed at that time, because that time the dual screening was not there for HIV and TB. So that was one thing. And the second case, as Dr. Satish has quoted, that there was a young boy of 15 years who was admitted with us. And we were suspecting pneumonia, but he had some unusual features, like there was no fever, but he had chest pain. He had complaints of breathlessness. And we asked him, what do you do? And unfortunately, that boy, because he belonged to a low socioeconomic strata, he was versed with the art of blowing a fire. So he used to put kerosene in his mouth and blow on the fire on all those processions or the weddings or other events happen. And unfortunately, this boy aspirated, and we could diagnose early point pneumonia in that boy. Always I would like to add is that it's a wonderful opportunity to relate with your patients. And though we agree that we are in the era of consumer protection, even if we want supportive documentation of n number of investigations that are available with you, or even those who are not available with you, every doctor would go to great lengths to see that the patient gets investigated in a particular direction. But take a history, do examine properly, and in general examination, never ever forget to look for lymph nodes. Because in this time, there may be more than one disease. We have been taught that whatever findings you get, try to correlate and come to one single diagnosis. But times have changed and patient can have multiple disorders at the same time. So do not forget, even if your patient has a short history of 5 days of fever, never forget to examine the lymph nodes in the neck, in the axilla, and in the inguinal region. Believe me, it's worth spending those 30 to 40 seconds in examining the lymph nodes, and be sure that there are no lymph nodes. Apart from this, before I end, I would say that whatever you have examined or heard from the patient, cut the story short, but do document few positive points as well as few negative points, which the patient says he doesn't have. Like, for example, he says he does not have hemoptysis. Then do write hemoptysis. He does not have hemoptysis in the notes. Don't assume that because you have not written, it was not there for the patient. It will also help in a long way in monitoring the patient, as well as in avoiding, as we said talked about CP. Or many times patient has scanty hemoptysis and they would ignore. They would, with some fear in mind, कि मुझे कुछ तो भी abnormal diagnosis मिलेगा, शायद मुझे cancer तो नहीं निकल जाएगा. So there we have varieties of patients. There are patients who have lot of fear in mind, so they want to tell more. There are patients who have fear in mind, but they don't want to reach to that particular diagnosis. So do ask positive and open-ended question and record everything that the patient answers to. That's it.
Thank you. Thank you. That was excellent, Dr. Radha, especially the...
And blood pressure. Something which I forgot to add is, do take your own blood pressure. I mean, do take blood pressure yourself. Even if you have juniors, even if you have a nursing staff, it's always better to take blood pressure on your own. It gives you time to talk to the patient. You can look at the pulse. You can look at the pulsations in the neck. Everything can be done at the same time when you are recording the blood pressure.
Absolutely right. That was excellent. And you also mentioned about how to use the time that is there, and brilliantly said that as you are examining the patient, you are also talking. So patient is connecting with you nicely. And everyone here is mentioning about the touch, very important. And
something. Please switch off your own mobile as well as ask your patient for that. Because it's a great distraction, and the patient feels कि मैं जब बोल रहा था तो डॉक्टर साहब तो सुन ही नहीं रहे थे. He was talking to somebody else, that he would feel. Right. And same thing, the doctor is also disturbed by the patient's mobile. So that can be a decorum also, which helps, it doesn't break your chain of thoughts.
Very well said. Very well said. Especially on touch, it reminds me of the conversation with Sadhguru, Dr. Devi Shetty, and he keeps talking about the touch, which is slowly losing, and then he keeps talking about it. And the mobile phone, excellent. And one of my caddy in the golf course, he was referred to a major hospital because his son had some problem. He came back and said, "Sir, they're always on the phone." They're always on the phone. I don't know whether I conveyed and they listened to me, and very well said. Yes, switch off the phone and then you can attend to it later. Small things which are important. We also learn from our patients, as you rightly said. And if there is something wrong, I would like to even change my attitude and become a good clinician. So let me move on to...
Satish, can I add?
Yeah. I'm just going to come to you only. Yeah, go on.
On the same history only.
Yeah.
I think a good clinician is a good listener. First of all, he should be a good listener. He should pay undivided attention to the patient. As Radha has said, I have seen patients are talking and you're talking over phone. So that's why when I'm making rounds, everybody phone should be in silent mode, including the residents and my phone. And you should have a confidence. Patients should have a confidence. Then only you will share some of the information which may be some of the issues like stigma and discrimination issues. I think you are a HIV practitioner. You might be knowing that unless patient has a confidence on the treating doctor that he will keep it confidential, and you should develop confidence that then only you can share some of the information. And sometimes the patient may not think that it is not relevant. That is why, as Surya Kant said, you have to probe like CBI, whatever it may be. Of course, not the attitude like CBI, but in a different heating touch attitude. You have to probe and
You're absolutely right. Way back in 80s, as you said, I used to examine thoroughly patients of HIV, not because I was going to get something out of it. Everything I used to examine thoroughly because nobody was touching the patient, as you rightly mentioned. So I used to examine from top to bottom, even though it was not important, because nobody was examining. Anyway, coming back
in fact, he shared in the TED Talk, one patient went to the topmost cancer institute in US, and she came back and she don't want to go to the cancer institute. And she told why means they have not touched her breast at all. Because they have the molecular level. Unless the patient human touch, the healing touch is not there, the patient will not develop the confidence.
Okay, so this question is to you, Dr. Subhakar. This is regarding percussion. So the detailed history, examination.
Shall you go in order?
Yes. Yeah.
Inspection, I think someone.
Those things are simple. She already mentioned.
Okay.
So you go on, because we have five minutes and then we have lots of questions. So
I think you already told about the percussion, the genesis of percussion, the history of how the percussion has come into clinical examination way back in 1700 from Anberger, who is a wine merchant. So percussion plays an indispensable role in the diagnosis of several pulmonary pathologies, particularly pleural pathologies. I used to ask one pathognomonic sign of pleural effusion, stony dullness on percussion. I think nothing is needed. Even the X-ray also sometimes may not be needed. X-ray also, it may show something like a pneumonia or it is a pleural effusion, or is a collapse, because all cast a homogeneous opacity. But if you percuss, if there is a stony dull note, suppose if it's a collapse, you get an impaired note. And if it is a consolidation, of course, they may be impaired to dull note. But the stony dullness and percussion definitely is a pathognomonic clinical sign of a pleural effusion. Not only that, you have to do the shifting dullness. You know whether the pleural effusion is organized or not. So unless my procedure does a shifting dullness, and you can't say whether it's an organized effusion or a typical pleural effusion. One more thing is a tidal percussion, which also plays an important role in your diagnosis, particularly to know whether it's a supradiaphragmatic pathology or infradiaphragmatic pathology, whether the diaphragm is paralyzed or not, to know the liver borders also. In fact, I have diagnosed a case of a dextrocardia by simply percussing the heart borders. The heart borders are on the right, and do not go for the sophisticated investigations. Some of the percussion can help. And of course, there is one patient was admitted with a chest pain in a cardiac ICU, and patients, they have done the TROP-T test and all the enzymes, and they are planning to do a coronary angiogram also. But unfortunately, the patient coronary angiogram is normal, and we have done a percussion. The percussion, there is a hyperresonant node on percussion. Do we need anything more than that for the diagnosis of pneumothorax? This is a real time, not just telling. These are the real time experiences I faced over 32 years of my clinical practice. Pneumothorax being admitted in ICU in the intensive coronary care unit, treated. In fact, they have started him heparin also at that time. So simply missed the pneumothorax. And similarly, so hydropneumothorax, you can see the horizontal level of dullness, the hyperresonant. I don't want to teach this. I know the audience is already a junior practitioner. So definitely percussion plays an important role. For example, left side pleural effusion. If TRAPS area is obliterated, what else you need to diagnose? If TRAPS area is obliterated, I say the left side. Unless my postgrad do these signs, and there is one more thing like auscultatory percussion. So the percussion is an indispensable tool. Many of the pulmonary pathologies can be diagnosed even without investigations by doing a simple percussion, and of course, including the tidal percussion and shifting dullness and auscultatory percussion. I think that is all for that. I can't go more into what are the rules of percussion, all those things. I don't.
Absolutely right. Yeah, thank you. That was excellent. And importance of percussions and how do you percuss, and those things are left to the basics in examination. So let me come to Surya Kant. Surya Kant, can you highlight something about auscultation? So we all carry stethoscope, and Subhakar mentioned that let the stethoscope be used rather than the Röntgen tube, the tube be used. So he mentioned. So, and we all use it. Everyone uses stethoscope. And when you carry stethoscope, you are a doctor. And so we all are identified by putting the stethoscope around our neck. Dr. Suryakant, your take on auscultation.
I think, yes, Dr. Sudhakar has already mentioned, yes, there is I think more importance of the Linux tube rather than Röntgen tube. So he has already mentioned the importance in his introductory remarks. So I think the stethoscope is your identity. If you are putting your stethoscope, there is no need to introduce yourself that I am so-and-so, Dr. So-and-so. If you are with the stethoscope, everybody knows, even a child can identify that the doctor is going. You see, one of my important seniors, teacher, they always keep a stethoscope. You see, I don't know why. And one of my, like elderly brother, if you all remember Dr. KK Agarwal, his identity was also with his stethoscope. One of my teacher was still alive and healthy. Of course, unfortunately, Dr. KK Agarwal died this year due to COVID. But one of the teacher in medicine department, Dr. CG Agarwal, he is also putting every time a stethoscope. Everywhere, every place, his identity has become with the stethoscope. So, that is you see the importance of a stethoscope. And if you see, patient may be suffering any disease of any system. But if you are not putting a stethoscope, he will say, Ala to unhone lagaya hi nahi, Ala sa to dekha hi nahi, stethoscope to lagaya hi nahi. What he has seen, he has not seen anything. So, they expect, even the fractured people, they expect that you should put a stethoscope and examine it. So, I think it's a perfect clinician is that you always keep your stethoscope, and of course, you practice with the stethoscope. Auscultation is the beauty. You see, during the breathing, of course, there is some sound, and they can be transmitted to what extent, to what degree, to the chest wall. That is the beauty of assessment of by stethoscope. If there is a hindrance in the conduction of sound, you will find a little different kind of sounds on the stethoscope. So the intensity of the sound that you mentioned, that yes, sounds are heard normally, or they are diminished, or their intensity is less, or there is a character is different. I mean, so many things. I think every audience knows how to go for the auscultation. We, especially when there is a breathing pattern, so normal vesicular breathing pattern, then abnormal pattern of bronchial breathing. Then, of course, out of the bronchial breathing, of course, as you mentioned, whether this is the cavernous, whether this is the tubular breathing, or this is amphoric breathing, and what can be the possibilities for all these breathings. Then, of course, there is an important thing, the adjuvant during auscultation, the additional sound, for example, pleural rub, or you are finding some bronchi, or you are finding some clefts. And there is usually a lot of confusion between the pleural rub and the crepitation, usually coarse crepitations. So then you can find out that, but of course, when you put more intensity over the chest with the stethoscope, you will hear more profoundly the pleural rub, but there is no change in the, of course, the crepitations. And if you just ask the patient to cough, then of course the place and of course severity of clefts, they can be changed, but pleural rub, it will not change. And of course, there will be a little tenderness also on chest wall on that area where you are hearing the pleural rub. So these are the very interesting the men auscultatory finding regarding the character of breathing, then of course type of breathing, and then of course additional sounds. So very important. So I think auscultation is like listening the lung sound with your added instrument that is called a stethoscope. One more thing I want to mention regarding the history. You see, that Dr. Radha mentioned a beautiful point, and Dr. Subhakar also mentioned beautiful point. You see, I am known in the Uttar Pradesh for the one-liner messages. So my latest one-liner message is, usually hospital is known for two things, the safai and dawai. Means safai means cleanliness, dawai means medicine. I added one more thing. That is sunwai. What is that sunwai? मरीज कहता साहब भर्ती तो हो गए लेकिन सुनवाई कोई नहीं है. Nobody is listening to me. So that's important, very important. History is basically sunwai. Listen carefully. So my one-liner message for the quality of hospital is safai, dawai, and sunwai. Sunwai has become very important. History is very, although WHO says that you devote 20 minutes on history, but in this country, due to overburdened physicians, we don't have any time. So I think we should increase the capacity building. We should have the more sensitization of the peripheral health institutions in this country, so that we can, of course, cut the load on the tertiary care centers, on the major cities, and so that we can have more sunwai for our patient. So this is the art of, this is what art. So Radha, Dr. Radha has already mentioned that, yes, of course, medical science is science as well as art. So the art of auscultation is important, art of history also important. So I think I also witnessed that oration delivered by Abraham Varghese probably 10 years back in 2011. And the oration, his topic of oration was the percussion. So he emphasized on percussion. So I still remember that talk. And of course, that always reminded me that I must teach the importance and significance of history taking physical examination. And of course, especially your identity, that is stethoscope, the auscultation. Thank you.
Yeah, excellent. Excellent about auscultation, and very important. And your single liners are always well known. And we all did that. We went back to the patients again, especially in government hospital. We went and listened every morning, even though we had heard the previous day, just to hear that tubular breath sound, or an amphoric or a cavernous breath sound. And many of us in Bangalore, we used to go to the TB sanatorium to hear the large cavity sign, which is the cavernous breathing, and then the metallic kind of situation in amphoric breathing, and so on. And humorously, I must remember here, one of us was auscultating in and out. And then somebody said, oh, there is an opening snap. This is about cardiac opening snap. There is a mid-diastolic murmur. There's also a fourth sound, and then an end diastolic. So all this, and then a loud P2 sound. I remember this. And humorously, one of my friend said, check your stethoscope. There may be a cockroach there. And you are hearing sounds. You're hearing opening snap. You're hearing all these noises. So, so that was nice. Okay, that was excellent. Let me come back. Something I missed was pointed out, Rakesh Chawla, regarding inspection. I just thought that it's not important. I think it is important. Let's go one by one. Sorry to have missed an important after. So regarding inspection, some useful tips for everyone here, Dr. Rakesh.
Before I come to inspection, I will have 2 lines about the history. You must try to talk in the local dialect to the patient to have a good connection. Stop using computers in your clinic, because either you will be feeding the data and patient is going to miss it. कि सर मेरी बात तो सुनते नहीं है, कुछ ना अपना कंप्यूटर पे करते रहते हैं और लिखे. They are giving the prescription. Third portion, I got a patient who had a massive subcutaneous emphysema, and the history revealed in no time that the younger brother went inside for the tube well switch on. The elder one was trying to pull the water from the tube well to come it in circulation and switched on, and his esophagus and the trachea ruptured and get into massive emphysema. So as Dr. Kandi was telling, it is an importance of the history. Now, inspection is very, very important, sir, because after the history, your points are going to get confirmed in inspection. Palpation further confirms, percussion reconfirms, and auscultation reconfirms all your findings that your diagnosis is correct. So inspection is very, very important. It should be done in a broad daylight or in a good lighted place. You see, as I said, stand 5 minutes, and these 5 minutes you are doing the inspection from his hair to the toe. Patient even is in his bed sheet. You ask him to expose his legs. You are seeing his eyes. You are seeing the tip of the nose. You are seeing his pattern of breathing. You are seeing his chest, whether it is a pectus excavatum or it is a pectus carinatum, giving you either it is the malnourished or it is a prolonged asthma, or patient has got a barrel-shaped chest, which is telling you patient has got advanced COPD. What is the pattern of his breathing? He is tachypnic, he is bradypnic, or his breathing is pursed lip, or he has got a Kussmaul sign. So you know by pattern of his breathing, seeing his lips, you know what diagnosis and what you are going to look for in this patient. So most important is when you are examining a chest, the shape, the size, the symmetry, the way of respiration, to see the apex beat, it is in place in the 5th intercostal space, mid-axillary line, or it is distorted. You are going to reach at a diagnosis from basic of dextrocardia to any clinical diagnosis which you are going to see. When you are examining the neck, you are going to see for the JVP. Again, you know this COPD with cor pulmonale is not there. You are able to see the venous engorgement on the abdomen to see whether the patient has got an ascites or the abdomen is tense. There is primary disease, as Radha said, regarding hemoptysis, and you are correlating patient maybe in a stage 4 of malignancy. You are coming down to look at the fields, patient has got a pedal edema. Now you go back in your mind whether this pedal edema is renal, it is cardiac, it is hypoproteinemic, or it is related with the primary disorder of the lung. You are seeing the arms, you are going to see telangiectasias, you are going to see the clubbing. As you said, mentioned, the ILD patient was not diagnosed. When you are seeing the patient has got a clubbing, you know the patient has either of the suppurative diseases of the lung, or he has got an ILD advanced, or he has the bronchiectasis, or he has got advanced malignancy. So when you are finishing the inspection, you have a fair idea at the end of the day what I am going to examine, which system I am going to address. Since we are pulmonologists, we have a tubular vision. So rather than having a tubular vision, keep your eyes and ears and your brain open. As they say, the X-rays, if mind knows, eyes will be able to see anything. So similarly, when you are going to do the inspection, your mind is open, which system patient is presenting, what problem he has. So from the pattern of breathing to pedal edema, to clubbing, to cyanosis, to the shape and size of the chest, placement of the apex beat, the tense abdomen and pedal edema, you know what I am going to deal with. This is how the inspection is very, very important. So thank you.
Okay. Thank you, Dr. Rakesh, that on the inspection, which I bypassed. Dr. Radha, you mentioned about general examination, especially on lymphadenopathy. Can you touch base the other things that like pallor and all that?
Yes. Yes, Dr. Satish, in fact, I know that I should have been a little more specific.
No problem.
After history taking, when you go on to the examination of the patient, the first thing that you should start is even if it's described in the books, the first is you touch the patient and let the patient know that now you are going to examine the patient. That's important. And then when you touch the patient and take the pulse, that is the time when you are also feeling the temperature. At the same time, you can also perceive whether patient is having sweating. That is also very important because a patient may have profuse sweating. For various reasons, like he had high-grade fever, or patient has had acute pneumothorax and he's in distress. So many patients start sweating, so that is to be recorded. Then next is you look at the pallor, or and you would look at into the in the tongue, or even in the conjunctiva it can be seen. And if you see that there is pallor, and when you look at the history, there are few things to which you must concentrate. One is, has there been a history of hemoptysis? One. Secondly, patient may say that he does not have, but he had it in the past. So perhaps that episode may have been of a massive hemoptysis. One thing. Now, if you look at various other conditions which may arise out of this severe anemia, so you should be able to correlate. So if there is a patient who has gross pallor and has palpable lymph nodes, then you have to think of either lymphoreticular malignancies which are existing, or there may be any other malignancy with secondaries. And now this pallor is the result of that pre-existing disease. That's one thing. Now, if the patient does not have lymph nodes, but patient has gross pallor and has edema feet, and patient has come to you with complaints of breathlessness, you should keep in mind that patient has severe anemia with edema feet, where it may be, I cannot say for every patient dogmatically that there is, but there may be some amount of fluid retention. And then as you go ahead with examination, and if you find that patient has pleural effusion with a gross pallor, edema feet and pleural effusion, you can clinically come to a conclusion that perhaps this is a transudative pleural effusion. That's one part of it. Similarly, then you go ahead in correlating all these findings. Now, if your patient has icterus, we should look at few conditions which may be associated with icterus in pulmonology. One, as we are commonly talking about, is about malignancy. So there can be secondaries and icterus may be the result of that. But I always feel that this is a very remote possibility. If your patient has icterus, the first and foremost you should be asking about is history of drug intake, any drugs. So your medical history of that patient has to be a very, very well elicited, so that you can correlate whether this is drug induced. That's very important. Then whether patient has any pre-existing hepatic disease, that you have to look at. And thirdly, then few of the patients who have pneumonias or have had hemoptysis and the blood has not come out, then there may be a possibility of hemolysis, which is of lysis of this accumulated blood, which may result in mild icterus that can be there. And whenever patient has itchus, and in few of the areas where it's common, one should also be looking at whether patient has underlying hemolytic anemias, and we should also look into that. When you go ahead with the general examination and if patient has clubbing, it's bad for the patient, but it's good for the doctor to come to diagnosis, because clubbing, if you observe clubbing, it narrows down your diagnosis in pulmonology to few of the things, which would be bronchiectasis, lung abscess, then lung malignancy, and lastly in idiopathic pulmonary fibrosis. So it narrows down your diagnosis. Then importantly, as I talked about lymphadenopathy, now if there is a patient who has come with complaints of fever, and you are examining a patient, fever and cough, and there are lymph nodes, then there may be possibility of infectious disease where there can be tuberculosis as well as coexisting lymph nodes. Whereas if there can be an underlying malignancy with lymph nodes, however, this fever may be because of something else. And of course, when you are examining for edema fit, it may be a result of existing, as I talked about, severe anemia, or as one of my panelists has mentioned, that this edema can be because patient has already landed up in cor pulmonale. And we almost always think that the patients of airway disease, especially COPD, would land up with cor pulmonale. But we see and we come across clinically many patients who have long-standing lung lesions and destroyed lungs. At that time also, cor pulmonale would come up.
Okay.
In cor pulmonale, edema can be seen. Then there are few things for which we must be looking at, and I would like to emphasize.
Like grades of clubbing?
Yes. I think that I would not be teaching them for the grades of clubbing, but I would definitely say that when you look for clubbing, just looking at holding the fingers and looking at the angle does not suffice. You have to go methodically and keep both fingers together and look at that the diamond sign, which is visible or not, and whether it has disappeared and there is a presence of clubbing. So that is very important, I think.
Okay.
And clinically, again, going back to the history, and when we were talking about pallor, I mentioned about hemoptysis. And here I would like to emphasize again the basics of differentiating between hemoptysis and hematomas. So how do you differentiate? In history itself, if there are symptoms of respiratory system involvement, like there has been cough, there has been fever, then perhaps this may be hemoptysis. Whereas if there are abdominal symptoms like of pain in abdomen, GERD, frequent vomitings, then this may have been a hematomas. Then ask the patient if it is not, the patient is not hospitalized but has come to your OPD. Ask the patient about the color of the blood which has been taken out. So if they say that it is a frank red blood, usually what I have found is that whenever there is hemoptysis and frank red blood, after expectorating also there is a tendency to clot. Whereas if the blood which is brought out is a brownish colored one, then perhaps it is coming from the stomach and it's hematomas. And if there are no preformed clots, what I have observed is that hematomas usually does not clot. I'm very sorry to say that I have not looked into the literature for any support of these things which I have observed. And I must apologize, because while coming on this platform, I should have verified about it. But unfortunately, I did not. In case I verify that, I may at least inform my moderator about whether whatever I have stated has been supported or documented into the literature. Then the third most important thing is that if the blood which is coming out is mixed with food, you must categorically ask the patient. Because if your patient has been coming to you earlier, he would come to you with every symptom. So if he has hematemesis, still he would come to you. So it depends, it is the onus or the burden is on you to extract a proper history. Then second important thing, what we have found is that, and we have noted, and it's there in the literature, that if it is hematemesis, then there may be some abdominal discomfort even after that, because all of the blood in the stomach would not be taken out. And what is important is that if patient has hemoptysis, then this patient continues to bring out small amounts of blood streaks in his sputum. So in the history itself, history of cough with sputum is important. And if that sputum then gets tinged with blood, then this is definitely hemoptysis. But of course, there are few patients who come with sudden hemoptysis or sudden bringing out of blood. And at that time, this is very, very important to differentiate between hemoptysis and hematemesis. And I think that all of us should emphasize on each and every point when you are taking history, especially of hemoptysis, because this is an alarming symptom. Here, just let me add that long ago, one of my professors, when he used to teach us about tuberculosis, he used to tell us that out of 100 symptomatics, only 90% of the people are aware that they have symptoms. Like they have symptoms, but they are not aware. 75% of the patients are aware about their symptoms and are action taking. That is, they would go, they are worried, but they may not go to doctor. They would just think that I have some symptoms. Of course, the times have changed, but this study was done very, very long ago. Only 50% of the patients who have some chest symptoms report to a doctor because they are aware, they are worried, and they are action taking. And 30% of the patients are disaster action taking. That is, whenever they would have disastrous symptoms, just like hemoptysis or very high grade fever or acute onset breathlessness, then only they will go to a doctor. So hemoptysis is a very alarming symptom, and you must pay time and importance to this symptom and extract a proper history.
Okay.
Many patients, but let me add that many patients complain about blood-tinged sputum, and especially in the morning. You have to extract a history. We are in India, and many patients have a habit of putting their fingers in the mouth and try to clean their throat. And thus, they are, even if they are not causing a physical trauma, their throat gets irritated off and on. And that is how they bring up sometimes blood-stained sputum. For this, you must also examine the throat, because whenever there is severe congestion in the throat, many times patient can have small blood-tinged sputum, which would come in the morning or after deep coughing, and then there would not be anything, any blood-stained sputum later on. I think I'll put off my video because the internet is a little weak. And I would continue with whatever I have been saying.
Yeah. Thank you, Dr. Radha. I think you touched everything, and especially stressing on the most important symptom, that is hemoptysis and hematemesis. Dr. Chawla, regarding cyanosis, can you throw some light on cyanosis? And with the pulse oximeter being available now, I think many of us forget to check for cyanosis. Go ahead and tell us.
I will like to add to Munje hemoptysis preceded by or followed by cough and sputum with the blood. But there are times when your history is not able to differentiate hemoptysis and hematemesis. Gastroenterologists say it is hematemesis. You say no, it is hemoptysis. It is not mixed with acid. It is not brown. It is red it is followed by, but still patient has a gastric symptom, then you are talking about hemoptysis and hematomas. X-ray chest is normal. CT chest is normal. Then pulmonologist has got a third eye. I call EBUS as a fourth eye to see beyond mediastinum. You have a third eye to look and see and finally settle the issue. You are dealing with hemoptysis or hematomas. So I will close. I will not go to the definitions of hemoptysis, mild, moderate, severe. But there is a fourth category, which is a fatal hemoptysis, and they don't include that hemoptysis into the category. The classification should be changed of hemoptysis when we are doing interventions and you are touching either the kind of an aneurysm, or you are touching a vascular tumor, or you are doing a cautery and it bleeds like hell. The whole department has got an adrenaline rush. You want to intubate and the code blue and intubation done. That hemoptysis, which is not possible, you put in a rigid tube, you put in a flexible tube, you are removing the clots from the young patient's mouth, you are looking to save endotracheal tube is blindly passed, hemoptysis stops with sigh of relief. Theoretical problems of rigid kar lo, usme flexible dal, suction kar do, nothing works. So this is a hemoptysis which is not in definition, and the definition should be changed, and this hemoptysis should be added in classification. So I will close here about hemoptysis, but as you said about the cyanosis, is again a very, very important. You said pulse oximeter. So you have to see the oxygen saturation, which depends on the hemoglobin concentration in the blood, cardiac output, color of the cutaneous pigment, thickness of the skin, and state of the cutaneous capillary. Sometimes your oximeter is not reading. You are putting a blanket to make the patient hot and see the oxygen. And all of us know cyanosis is central and peripheral. So where we see the central cyanosis, it is either because of the circulatory or a ventilatory problem. So the central cyanosis we see at the tongue, inner surface of the lip, and sites. For the peripheral cyanosis, we look for the tip of the nose, finger and toes. We see the ear lobules. We see palms and soles for the peripheral cyanosis. And we must know, when we cyanosis, we must reach at the cause of cyanosis. If it is a central cyanosis, you start thinking about COPD, bronchial asthma, you start thinking about pulmonary embolism, interstitial lung disease, severe pneumonias, hypoventilation, pulmonary veno-occlusive diseases. And if it is of the cardiac origin or a central cyanosis, you think of congestive heart failure, you think of the heart valve disease, you think of the recent MI. And if it is blood dyscrasias like methemoglobinemia, I will make aware the audience here today, we are using xylocaine so frequently in pulmonology practice. Have you have an antidote of the xylocaine in your laboratory, in your bronchoscopy suites? Xylocaine toxicity is a methemoglobinemia. Patient develops cyanosis and methemoglobinemia, and you have and you should have the cheapest of the drug, methylene blue, in your bronchoscopy suite to treat this cyanosis, which is because of methemoglobinemia, and you can have an antidote of xylocaine toxicity, which happens in the bronchoscopy suite. It may not happen in your lifetime, but when it will happen, you do not know the answer, how to salvage the patient. So try to keep 2 or 3 respules of the methylene blue IV, so to take care of your things. Then it can be polycythemia, sulfhemoglobinemia, or you have the congenital cyanosis, or you have the AV malformations, for which the echocardiography, you do the saline bubble test to rule out the AV malformations. And not before closing, obstructive sleep apnea, the forgotten entity, a very, very important thing, which is the snoring is not included in the syllabus of the undergraduates and postgraduates. History of sleep apnea, so many accidents happening, not included. So I think cyanosis was very, very important. I am thankful for giving the opportunity to elaborate on cyanosis and ending hemoptysis. Thank you, sir.
Thank you. Thank you, Dr. Chawla. That was excellent, actually, regarding cyanosis and as well as on hemoptysis. So I think it's 9:30. I think it's time for us to take questions. and there are few questions I would like the panelists to answer. There's one question from Gyan Shankar Mishra from Nagpur. Should there be a guideline regarding minimum consultation time for each patient by NMC? Dr. Kandi.
I think there are no specific guidelines that what time you have to spend on a patient examination. And around about, I think there are some guidelines in the US. So you have to spend minimum 20 minutes in the clinical examination of the patient. But NMC has not specified any guidelines that this much time should be dedicated to the patient examination. But they said patient examination is an indispensable tool. In fact, they have changed their syllabus also. When we are students, undergraduates, we used to go to the clinical postings after third year. Now, as per the new guidelines, NMC guidelines, the undergrads are exposed to the patients and hospitals and in the first year itself. So that is a change in the NMC, but there is no specific time, to my knowledge, that that NMC has specified on the amount of time to be spent on the examination of the patient. Radha, do you have
NMC has not specified. There have been studies which says that an average patient in India gets the least time given by the patient. Many times it's only in seconds and not in minutes. But recommended time for consultation is at least 15 to 20 minutes for each patient.
In fact, I worked in a primary health center during my initial days. There is a big queues in patients. So before the first patient comes, there at that time, everybody should receive an injection. If you don't give an injection, they're not happy. So the moment that the patient says something, the injection goes into this, and next time the next patient will go. So that is the scenario what we have come across, in particularly in the government hospitals where there is a high caseload. And that's why you should change something to how to improve our human resources. Should have enough time for each patient to spend. Of course, some persons have enough time also, but they don't give importance for the clinical examination. In fact, I don't want to name one of the senior pulmonologists in Guntur. He will see the X-ray first, then only patient will come. So patient has to send the X-ray to his clinic, to his chamber. He will see the X-ray, then call the patient. So that even that is, I don't want to name the senior pulmonologist.
So, sure. I mean, in short, I think
15 to 20 minutes, out of which you can spend at least 5 to 7 minutes on history taking, and other questions can be asked while examining the patient. And the last 3 minutes are for prescription writing and explaining to the patient in which way the medicines has to be taken.
In fact, I schedule my appointments, every second appointment after 20 minutes. So sometimes a patient may take 40 minutes. So then the next patient may have to wait. Some patients will come with a big bunch of records. You can't say that I don't have a time. I will spend only 20 minutes, as Radha said. So I will, after 20 minutes, I don't see any records. It varies from patient to patient. Suppose if it's a first time visit, you have to spend more time. Suppose if it's a patient coming for a second consultation, we know everything about that patient. May not take so much time. So that depends upon the patient, whether it's a first consultation or second consultation, with how many bunch of records he has come. Of course, the case also matters.
It's all time management. And Radha was mentioning, as you're examining, you're also talking. So we all learn how to manage this time. And fortunately, or with experience, all of us learn. And Indian doctors are acclaimed to be good clinicians and recognize diseases in a quick way, and then also have practical suggestions. As you rightly said, there are thousands of patients waiting for doctors in the rural area in PHC. So let me see, and I read somewhere about clinical examination of respiratory system takes about 6 minutes. If you do a thorough examination, and by an experienced chest physician will take about 6 minutes. Let me see what is the next question. There's a question about Dr. Naeem Dar, Jammu Kashmir, good friend. We are in the era of evidence-based medico-legal cases, available, refined, advanced investigation, and hope for quick results. How can we sustain with all these things with history and examination? I think we have all answered about this, Dr. Dar. Also, he goes on to ask, government hospital have so much rush, hundreds waiting. I think we also did that. And all young doctors just make use of investigation and go for examination. And that's why I think this webinar is to change mindset for juniors. And there's no shortcut in medicine, and you have to practice. And then you learn
Dr.
how to
Satish.
deal. Yeah. Yes,
Dr.
Surya.
Satish, I think this question which came from the Jammu and Kashmir, it's a very pertinent. You see,
Yeah,
we can
absolutely.
see that before 1994, the medical profession was not under the cover of Consumer Protection Act.
Yeah.
After this 1994, the medical profession was included in the Medical Protection Act. So that was the change from we started the decreasing trust, faith, bonding between the patient and doctor. And this is still continuing in last 2.5 decades. So
Yeah.
I think this is a very important issue. And my formula is that first you protect yourself, second you protect your fraternity, and of course third priority should be the community. Because if you are not protecting yourself, you won't be able to protect anybody. So
Yeah.
I think the era has come. Yes, the doctor-patient relationship has come at the, of course, at the verge of, you see, a lot of medical-legal entangles. So I think first priority is always to protect yourself. So whatever you are doing, documentation is necessary. Documentation is the only thing which will save you in the court of law. It is not your perception, it is not your well wishes, it is not your gesture, it is not your knowledge, it is not your skill, it is not your degree which will protect you. It is the documentation which will protect you in the law of court. So I think that should be the, of course, and I think the time has come. I used to say that time has come when we were the MBBS student, we used to see how to diagnose the patient, how to treat the patient, how to diagnose disease, how to treat the disease. पहले हम सिर्फ मेडिकल एजुकेशन के दौरान पहले हम सिर्फ बीमारी का इलाज सीखते थे. द टाइम हमको बीमारी का इलाज भी सीखना है, हमको बेवकूफी का इलाज भी सीखना है, हमको बदतमीजी का इलाज भी सीखना है. अगर आपने तीनों बी का इलाज नहीं सीखा तो यू कैन नॉट सस्टेन योर मेडिकल प्रैक्टिस. बीमारी का भी इलाज सीखिए, बेवकूफी का भी इलाज सीखिए, बदतमीजी का भी इलाज सीखिए. देन ऑल दिस इज द मैसेज फ्रॉम आई एम नेशनल लीडर ऑफ IMA suggesting you. Thank you.
Thank you.
Sorry, I want to take the leave because I have to go from other program. Dr. Satish, it is already time. So it was a wonderful program from CCI. My best wishes to the Krishna, to the Pradeep, and all the office bearer of the CCI. You used to give me an opportunity for interacting with the younger people. So I wish a great success for these all ventures of CCI. Thank you, Dr. Satish. It was wonderful, of course, interaction with the people. And of course, under your able leadership as moderator. Thank you. Thank you very much.
Thank you. Thank you for joining. Excellent. I think. Thank you. Yeah. Yeah. Sure.
I will add what Surya Kant said. The whole, as you said about documentation, the whole file. If your institution is corrupt, you are corrupt. You can create the whole file again by sitting in your place, by calling the same staff nurses. I tell there is one paper you cannot read. It is a prognostic sheet. You must explain truthfully the condition of the patient. Ask the attendant to sign that paper and let him understand what the patient is suffering and what is the possible result. That is the only document which will save, which will hinder them to create any nuisance on the day one itself. And ask him every day to sign before you are coming to the round that my resident has explained you. If he has not explained you, please complain to me. I move the reverse order. I tell them to please sign before I come. I want to see this paper signed. That is the only document which hinders him to create a nonsense and which protects you in court of law. Rest the society does not believe you today. They have no faith. We were gods, we are not gods. In 1 minute you are God, and another minute you are DOG. So you be careful, must explain the prognosis, get it signed, put it in the file, and go and sleep peacefully. I am sure everything is taken care of. Just wanted to add to the documentation. Thank you, sir.
Yeah. Thank you.
Rakesh, not only documentation,
Yeah.
in fact, in our institute, we do every week audit of all the documents. All the case sheets of the departmental audit committee is there. We'll audit every minute detail of the documentation to avoid these medical legal problems.
Thank you. That was excellent. Thank you. And there is one question here. Dr. Gautami from Uttar Pradesh asking about, I think Dr. Kandi, you can answer this, vocal fremitus and vocal resonance note in fibrosis. The books mention that increased note, whereas some books mention dull note. Can you please clarify on this fibrocavity and fibrosis?
Can I come in before that, Dr. Satish? I'm so sorry, Dr. Subhakar, to interrupt.
Sure, sure.
See, basically, when we teach and when we learn about examination of respiratory system, what is important is that all of us understand how are the sounds conducted. So what allows the sound to be conducted is that the airways need to be patent, one. Then between the chest wall and the airway, there should be a conducting media. Then only the sounds which are either breath sounds or artificially produced, or we ask the patient to speak, that would be heard at the one end of your larynx tube. That is very, very important. Now, when we go back to the question which has been asked, we
You want to answer? Okay, go ahead.
No. You are going to answer. I'm just trying to explain the physics because this always comes up for a debate.
Yeah.
So if there is a consolidation where you are supposed to hear bronchial breath sounds, because the sounds are being better conducted, the airways are patent, there is a consolidated lung, which is a good media of sound conduction, and it's at the chest wall. If at all, there is something like pleural effusion which comes in, and the fluid is not conducting the sounds, then at that time, you will not be able to hear all the classical signs of pneumonia or consolidation, because that is being hampered by the fluid. So once you understand how the sounds are being conducted, similarly, like there is a mass and you are otherwise not hearing any sounds if the airways are collapsed. But if the airways are patent and the mass is nearer to the chest wall and it's able to conduct the sounds or is conducting, then perhaps you may sometimes hear increased sounds. Otherwise, you will not be hearing the lung sounds clearly. And now Dr. Subhakar would answer the specific questions about fibrosis.
Thank you.
Sorry to take up your time, Dr. Subhakar.
No problem. Yeah, thank you for bringing the basic physics of lung sounds. When I am postgraduate, I used to read one book called 4 Gags on lung sounds. It has beautifully described how the sounds are produced, how the sounds are transmitted. This is a beautiful book, and there should be some conducting media to transmit the sounds so that we'll hear the sound. I think you have given some basic inputs about the sounds production and sounds perception of by the clinician. So coming back to the question straight away without wasting time regarding the vocal fremitus and vocal resonance. Vocal fremitus is a palpatory finding. Vocal resonance is a auscultatory finding. So they should go hand in hand. Vocal fremitus is increased, vocal resonance also increased.
Yes.
That is why always when I teach my postgraduates, vocal fremitus depends upon the perception of our hand. Sometimes you may not pursue properly. So that is why I ask them to go for a vocal resonance directly, and whatever the finding is there, you write in the vocal fremitus. So coming back to the fibrosis, what happens when the fibrosis, if the airways are coming close to the chest wall, then it will conduct when it is patent, it will conduct the sound, the vocal resonance or vocal fremitus is increased. This is simple. I think Radha has told. In some cases, if they are not coming close to that, for example, in collapse, the vocal fremitus will be diminished or sometimes absent. For example, in pneumothorax, vocal fremitus is absent. So in fibrosis, depending upon whether the fibrotic, because of the fibrosis, where the airways which were patent have come superficial to the chest wall, then we'll hear increased vocal fremitus. If it doesn't, there will be decreased vocal fremitus or vocal resonance. Thank you.
Okay.
And especially in pleural fibrosis, if you have a dense pleural fibrosis, sounds will not be heard and or they would be decreased.
Yeah. Yeah. So again, it depends between whether it's a parenchymal fibrosis or a pleural fibrosis or pleuroparenchymal fibrosis. Depending upon the fibrosis, the sounds may vary. Suppose if it's a pleural fibrosis, definitely the sounds, the vocal fremitus will be decreased.
Okay, excellent. That's excellent. Rakesh, go ahead. You have something to say?
Sir, as I told, beautiful art is in respiratory medicine: inspection, confound by palpation, confound by percussion, confound by auscultation. Your bronchial breathing, vocal fremitus, vocal resonance. The fremitus is confirmed by vocal resonance. Bronchoscope, the bronchial breathing is confirmed by your whispering bacteriology. You can confirm each and everything at every stage. You don't need an examiner to come and say कि ये finding है कि नहीं है. And another thing from the history, I was remembering a story of a sadhu who is Maharaj. How the Maharaj is made? Maharaj is made by the Shishya. So Maharaj is sitting inside. Shishya will give him 2 bananas. He knows he is asking for the son. He will give 1 pomegranate. He is asking for marriage. He will give some other combination of fruit, so he knows his desire. So similarly, you can tell your juniors to take an history of the patient, brief you before you coming on the rounds, and when they know about this, the attendants, what they know about that, my senior doctor knows about this, he gets amazed. He feels so good that my doctor knows all in detail. So you are made Maharaj by your Shishyas outside the Shiva when they are entering into the system. Thank you. I wanted to put these comments.
Okay.
Here.
Yeah, thank you. That is a nice tip for every busy physician.
But one thing I think, Dr. Satish, we must add is that you can even give pre-form questionnaire type of history, which can be written by the patient's hands themselves. That would be like patient himself has given a record, and it would stand for this CP litigations, if at all. But importantly, whatever patient has written or whatever your junior has recorded, I think few of the important points must be validated from them. Like somebody would say, I'm not hypertensive. And then if you ask, are you really not hypertensive? वो डॉक्टर साहब 2 साल पहले एक बार बीपी हुआ तो वो गोली लेने के बाद मेरा नॉर्मल हो गया. एक बार हमारा शुगर बढ़ के आया था गोली लेने के. तो many times it re-emphasizing or revisiting important things would definitely help.
Thank you. Thank you. I think that was nice. I think we are winding up with 1 or 2 small questions. I think it's important for the audience who have asked this question. This is from Value Give Clinical Model. Okay. Nivedita Suresh, Karnataka, asking respected teachers, what are the examination findings of bronchiectasis other than core scriptations and clubbing? So
halitosis, something which I should have mentioned, that when patient walks in, halitosis. And I remember, if a patient of bronchiectasis or lung abscess comes, everybody would screw their noses and everybody would ask, kya ho gaya, kya ho gaya, kya ho gaya? Aaj cleaner nahi aaya kya? But that is actually the patient who is walking in. And I have myself experienced, and I'm sure many of us have done.
True.
I think when the bronchiectasis comes, 3 points you have to, 1 in the history,
yes,
1 in the general examination, 1 in the auscultation. These 3 things will help to diagnose a case of bronchiectasis. For example, if the patient is having a copious amounts of sputum with a purulent
postural relation,
with postural related, and on auscultation, coarse, leathery, creaky crepitations which are unaltered with cough, and of course there is a clubbing.
Yes.
That's right. Thank you. And the same doctor is asking Nivedita, what are the clinical tests suggestive of diaphragmatic palsy other than the Lytton sign and paradoxical breathing? Anyone wants to take it up? Is there anything?
I think I discussed to know the diaphragmatic pathologies, the tidal percussion will help.
Tidal percussion, you mentioned about it. Yeah, that's nice one. There is also a video demonstration of that. And Dr. Nivedita, you can look up for that. Okay. She goes on to ask, what is the definitive clinical sign of cavernous breath sound? I think Dr. Rakesh mentioned you go on confirming with each one of them, one after the other, and that is going to be a definite sign of clinical. Okay. Okay, the last one, I think, for today's webinar, which is the best clinical book to refer for clinical examination of respiratory system other than Hutchison, MacLeod, Goldwala, kindly suggest. I think there were discussion, Dr. Rakesh and Suryakant mentioned about a book.
Basant Hazarika's Bedside Respiratory Medicine, a wonderful book. With lot of
your patient is a good book rather than all this. You go on examining the patient. Go on examining.
Yeah, I think it's time for all of us to say goodbye to all our viewers, and thank you so much. I had great time, I must say here. I was very nervous because there's no slides here. And then all panelists did a wonderful, wonderful job and a great concept by Dr. Krishna and his team. As usual, even though it's too late in the night, I think all of us are eager to answer these questions. And I'm sure all of us have learned, not only the audience, all of us have learned, and from each other, how we have managed patients, clinical history, examination, shortcuts in the era of COVID, and when time constraints are there, when we are also fraught with danger of touching patients and so on. We have done excellent, I must say. And thank you, everyone. And good night. And the technical team and the Cipla who are regular sponsors, Dr. Krishna and the team, Dr. Vijay Kumar. I know I didn't answer one of your questions that you posed, and we'll do it some other time. And thank you so much. Thank you.
Thank you.
Yeah. Thank you, Satish. I think there are some more questions. If they want, they can send these questions, share later. We can answer detail those to specifically to persons, because some of the postgraduates have raised so many questions I'm seeing in the chat box. We can, in the interest of time, we may not cover, but these questions can be answered through email in the later time.
Yeah. Thank you. Thank you, everyone, and good night.
Thank you very much, Dr. Munje. Nice to see you all. Thank you, Krishna Bhai. Thank you very much. Thank you.
Thank you. Thank you, Team CCI. Wonderful moderation, Dr. Satish. Thank you, Krishna, and all my colleagues and friends, Dr. Rakesh, Subhakar, and Dr. Suryakant. Thank you for giving this opportunity. Thank you. Good night.
Thank you. Good.
Okay.
Good night.
Bye. Bye.
Bye.